Good afternoon, everyone, and a warm welcome to this Boost Connect and Learn session. I'm Catherine Grayling, and I'm the lead for Boost, which is our learning and improvement community in North East and North Cumbria. So, it's brilliant to see so many colleagues joining us from across the health and care system today, and that's people from the NHS, voluntary community sector and beyond. And today's session is going to be focused on staff sickness and well-being. And the aim, as always with Boost, is to connect, share and learn together. So these connect and learn sessions are designed to do three simple things. So we're going to be sharing and spreading improvement work, connecting with like-minded colleagues around a specific topic, and generating ideas that you can take back into your own organisations and teams. Now, whilst today's session is around improving attendance, it's more importantly about how we can make work itself healthier, more sustainable and more human for people. So we have a couple of presentations for you today, and we're going to be starting with colleagues from the North East and North Cumbria Provider Collaborative, led by Lynne Shaw and Nicola Morrow, who will be sharing the system-wide work underway through the Sickness Project Delivery Group. This group brings together HR and workforce leads from across all our provider trusts with a shared goal of achieving a 1% reduction in sickness absence across the system. And they're taking an analytical and evidence-based approach, using shared data, aligning policies and learning from what works in different organisations to move towards a more consistent trauma-informed wellbeing model. And then we'll be hearing from Lancashire Teaching Hospitals NHS Foundation Trust. So Jennifer Carroll, Rachel O'Brien and Stuart Clough will be sharing their rapid improvement workshop on sickness process. And this session brought together over 35 colleagues from ward managers right through to workforce and staff, and they used guided conversations and measured psychological safety in real time. And their results speak volumes. So their long-term absence cases have significantly been improved in the last 8 months, and temporary staffing hours fell sharply. So they're going to be talking us through kind of what made the difference in their hospital trust. So together, these examples are going to highlight two really important ingredients of sustainable improvement, so system alignment and local ownership. So let's begin by hearing first from our provider collaborative colleagues. So I'm going to hand over to Nicola and Lynne, and they're going to talk us through the latest information around what our NHS trusts are doing together. So over to you guys. Welcome.
Thank you. Are you there, Nick?
Yeah, I'm here, Lynne.
Great, thank you. We did have a discussion about how much time we take on this session in terms of what we're doing across the system, and I'm much more keen to hear about what Lancashire are doing. So what I'm going to do is just give a very, very high level and brief presentation on some of the work that we've been doing over the last few months, and then I'll hand over to yourselves to tell us all what you're doing down in Lancashire. So next slide, please. So about 18 months ago, Deloitte did some work for us linked to our medium-term financial plan. And this resulted in the development of a workforce programme board. And that is chaired by one of the chief execs across the system, Trudy, who is interim chief exec at North Cumbria Integrated Care. As part of that, 4 delivery groups were developed, one looking at bank services, one looking at recruitment, one on occupational health, and one looking at sickness delivery. We've since added a 5th, which is looking at the mental health and wellbeing hub across the region as well. I chair that group, and we meet roughly monthly, and every trust is represented on that group. And we've collectively been asked to reduce sickness absence across the region by 1% by the end of this financial year. As part of the work, which is really well supported by the Provider Collaborative, we've developed a delivery plan, which is on the next slide, which I'm not going to go through in any detail, but we have some target timescales in terms of the Q4 from last year taking us through to Q4 in this year, at which time we are expected to make those 1% reductions. Next slide, please. I'm just going to spend a little bit of time talking about the data across our region, across our system. So the 12-month rolling absence is 6%. That's across the whole ICB. And you can see from that red line that some trusts are below that 6% and some are above. When we looked at sickness historically, every trust just about across the system has seen an increase since COVID. And although there've been some really good work and some reductions in some trusts, it is something that we're really struggling to get down. We know some of that is linked to the area that we live in, the deprivation in the area. And I know, for example, the Northwest have got a similar demographics in terms of their deprivation. And I know they're struggling as well. But what we have seen is an increase since COVID. And that's one of the things that we've been trying to get to the bottom of. You can't see the detail in the table, and I can't actually see what it is, but about 36-37% of our absence is mental health related. We do have the regional mental health and wellbeing hub, and that's proved to be really helpful for us across the system, and more work is being done on that, but the mental health related absence is huge. We know that our unregistered workforce have the highest absence rates, and our doctors have the least, and it's between our unregistered and then our nursing and midwifery staff who've got the highest. What we have been doing over the last few months is looking at what we can do to reduce absence, and we've done a lot of benchmarking and baselining work over the last 2 or 3 months. We know in terms of our professions, in terms of our age groups, in terms of our areas, we know exactly where the issues are, and the work that's ongoing now is to look at how we can try and reduce absence, and whether that needs to be a targeted approach or whether that needs to be just across the region generally. That's what we're looking at. Next slide, please. So most of us have got a BI dashboard and find it very useful to be able to gather the information very quickly. Some of them are in real time, some of them aren't. We do have a couple of central reporting hubs. So North Cumbria Integrated Care and NEAS have centralised absence recording, and from CNTW had a central absence system and moved away from that for a number of reasons. So we've been looking at both how we can develop this work through dashboards, but actually also look at what is the best methodology in terms of central versus devolved. I've talked about the mental health and wellbeing hub. We've also got the occupational health project delivery group. So these are 2 of the 5 key elements, and will really help towards supporting our sickness reduction. So the mental health and wellbeing hub has been in place since COVID. They were across the country for a period of time, but following COVID, and many of the regions decided that it wasn't cost effective anymore and stood theirs down. We continued with ours, and with the help of some funding from the Health and Growth Accelerator, we are in the process of developing that further and enhancing our model, including bringing in more physical health related support, for example, around obesity, alcohol, menopause, etc. as well. Our occupational health project delivery group is looking at options on how we can support all of the trusts in our region around their occupational health offer, and there is a paper currently in draft about what that might look like, and that could be as far as having one occupational health officer across the region. Again, that work is still ongoing. Next slide, please. So in terms of some of the things that we've been doing, we've looked at our absence policies, and I have to say there is very little difference in the policies across the region. The biggest difference is around how we apply the policies. So, for example, we have different ways of applying bereavement leave, disability leave, medical suspension, fertility, etc. And that is something that we're currently looking at as a group to try and get as consistent approach as we can. In terms of sharing of policies, we've shared policies, we've shared our triggers and our indicators for absence, and there's very little difference across the region in terms of that as well. So the next thing that we want to look at is what we can learn from other regions. So this came up at a really good time. So thank you, Lancashire colleagues, for agreeing to come around and share your experiences. We feel as though we've now got to that nub in what we're doing in terms of our ICB area, and want to learn from others to see what I suppose, what processes and what mechanisms you've got in place. And I know you have had some real good developments from the work that you've been doing. So it'd be really good to hear about that today and see what we can learn and take forward in the work that we're doing. So I don't know if Nick, you want to add anything in addition to that?
No, as Lynn said, we're kind of open to look at sharing and working closely with other areas to see what works. We know this is a really complex issue in terms of absence management and managing sickness, and we know we're not alone. So we're here to learn and to take everything on board.
Thank you, Catherine.
Thanks very much. So we're going to move straight into the second presentation, and then we'll have an opportunity for questions and answers at the end. So I think that gives a really brilliant framing of the macro kind of cross system level work and how data can be used to inform a unified approach. But now we're going to hear from the Lancs and South Cumbria team. The Lancs Teaching Hospital team about the work that they've been doing internally. And I think this gives us a real chance to look in detail at some of the more qualitative relational data that's improved their approach. So I'm absolutely delighted to welcome the team, and we'll hand over to them.
Thanks, Catherine. I think so. My name's Stuart. I'm Associate Director for Continuous Improvement, and I'm joined today by Rachel and Jen. I'll let them introduce themselves as they come on and talk. I'm just going to kind of give a bit of an opening just to set the scene, just to show you how we've applied improvement methodology to the challenge that we're presented with. Obviously, looking at ways that we can reduce sickness absence, but doing it through an approach that we've taken probably in the last 12 months in the organisation. At this point, I'm just going to ask the awkward question: do you move slides for me, or do you want me to take control? It looks like someone's moving them on, so that's absolutely fine. I'll just carry on, and I'll just say next slide when I'm ready for it. So basically, just to let people know what we've been doing. So obviously, Rachel and Jen will tell you a bit more about the content, particularly Rachel. But what we wanted to do was apply some improvement methodology to looking at ways to reduce sickness absence in the organisation. Just for context, we've taken some, a bit like you're doing from us today, which I think is a really positive thing. So thanks for giving us the opportunity. We learned from Leeds Teaching Hospitals around their approaches, particularly around reducing variable spend, but they used an approach using rapid process improvement workshops. What we have done for the last 12 months is take that process, because what we find is it yields really good impact. I think the key things are that it brings people together, we get ideas out in the room, and we're able to explore things quickly and then create a plan. So although it's a rapid process improvement workshop, we don't fix everything in the week. What we try and do is identify the short-term, medium-term and longer-term wins and have a really coherent plan around that. And you'll see that hopefully within the presentation this afternoon. I think just to talk a little bit further about the rapid improvement workshops, what it's been able to do in this situation is let us to think about understanding the problem deeply. So what we want to be able to do is understand the problem at hand. Who are the right people? So how do we co-design some solutions, and then what's the mechanism then for deliver, and then crucially, which is always difficult within health and care, is how do we actually sustain the gains that we've seen. So really, as I said, what we wanted to be able to do is understand the key challenges, use data both qualitatively and quantitatively, and think about ways that we can proactively manage the issue that we're faced with. I think the key things behind a rapid process improvement workshop, so forgive me if people are well versed within this methodology, but the key thing is around really looking at current state analysis. So what do things look like now, and that delves into what the data is looking like, that looks into your process in your system, that looks into people, relationships, etc. But then quickly, how do we all get together around the table? So rather than trying to connect things up outside of this kind of forum, this has been a really quick way for us to be able to develop a plan, and then that's helped us then to keep the improvement methodology going. If we just move on one more slide, whoever's in control, that'd be great, thank you. So these are just the key steps. Won't labour the points. I want you to hear from Rachel and Jen about the actual sessions itself, but just these are the key steps. If you were thinking of taking a similar approach, these are the things that we found really useful. So getting people in the room, getting everybody in the same mindset, creating a standardized shared approach and vision, deeply understanding the data, thinking about the best practice, learning and sharing best practice, that's really important. Then how do we test it and then build some confidence in the intervention? So using quality improvement methodologies to then start to think about, well, how would we start to spread this and then scale this up right across the organisation before we think about hardwiring it into the fabric of the organisation, thinking about implementation techniques just so that it's business as usual. And then we want to track the change over time. So we're really keen moving it from a quality improvement process to a quality assurance process. At this point, I'm going to hand over to Rachel, who'll tell you a little bit more about the challenge at hand and then how we've addressed it.
Thanks, Stuart. So I'm Rachel O'Brien, Associate Director of Workforce for Lancashire Teaching Hospitals. So I'll say a little bit about the context that we were faced with when we started the work around using improvement methodology to try and reduce sickness absence. I think it's fair to say that early in 2025, we were under really quite considerable scrutiny externally around our sickness absence levels. And those sickness absence levels were also causing us numerous internal challenges in terms of the staffing gaps that they were creating, the level of temporary staffing cover and the associated spend with that. And the Northwest, as we've already touched on, historically has had very high sickness absence. In fact, the Northwest is persistently the highest sickness absence in the country for reasons relating to population health. But we were in the very difficult situation of when looking at acute trusts, we were constantly around either the worst, the second worst, the third worst, and that wasn't the best podium to be stood on, really. Certainly not an accolade to be proud of. So we recognised that we really needed to take a different approach to trying to reduce sickness absence, because despite in the last financial year, so 23-24, having a very lengthy sickness absence reduction plan with about 100 actions in it, we weren't making progress. And as the slide shows, our annualised absence rate actually went up in 24-25 compared to the previous year. Now, when we started to unpick that and look at the data that sat behind it, what was interesting was that the actual episodes had gone down. They'd gone down quite considerably. And what we were seeing was that the short-term absence rate, so less than 4 weeks, was relatively static, but our long-term absence rate had gone up. So less episodes, but people staying off longer. So we started to think about how we could try and target ourselves around long-term absence to try and make some focused inroads. Would you mind going on to the next slide, please? And in particular, we observed when we looked at the data that our biggest issues with sickness absence when we're looking at days lost due to sickness were in the registered nursing and midwifery groups and additional clinical services, which tends to include healthcare support workers. So we felt that what we needed to do was try and engage the leaders from those workforces to work with us in the first instance on the rapid improvement approach. Next slide, please. So in terms of the scale of the challenge, we knew that we wanted to try and create a targeted focus using improvement methodology, and we wanted to try and start with a concept, so something that we felt we could really work at to try and make a difference. So we worked out that if in the previous year we'd had 10,000 less days lost due to absence, that would have lowered our year-end annualised rate by about 1/3%. So that doesn't sound very much, but when we think about 10,000 unproductive days and the cost associated with that, that would still be a significant improvement for us. And then we worked out that actually if we reduced absence duration by 31 days on 322 long-term cases, that would give us those 10,000 days. At any one time, we're carrying an absence caseload of around 450 cases. So that felt realistic, and it felt like a bite-sized challenge that we could set our clinical leadership teams to work with us on. Next slide, please. When we thought about some of the practical barriers to progress, some of the things that we identified were there were numerous instances of excessive slippage in case management. So actually, it probably won't be too difficult to find those 31 days on each case. Some of the issues that we were observing were managers took minimal action before 3 months of absence duration in most cases. 3 months is typically the point at which we start to provide them with some dedicated HR support around long-term case management. We do expect them to try and manage it themselves and informally up until that point. It was really clear that there was a reluctance to act in cases involving serious health issues. So cancer, significant mental health issues. Some of that was around managers not feeling confident. Some of it was around its genuine absence. But in general terms, there wasn't a lot being done around those cases until HR really tried to drive an intervention. There was generally a lack of sense of urgency to arrange absence review meetings. Some of that stemming from managers' capacity, but still a lack of sense of urgency. And there would be real sort of time lost due to information not going out, or information going out to wrong email addresses, or managers being on leave. And it was very easy to see how slippage was building and occurring in the management of absence cases. And given that we know that the longer people stay off, the harder it is to get them back because of the psychological barriers as well as the physical ones. We felt there was an opportunity to make a real difference if we could drive behavioural change, particularly within our management population. So that all led to us wanting to really engage with our clinical leadership teams and having a shared focus on what we could practically do together to try and work these issues through. And I'll hand over to Jen, who will tell you a little bit more about what we actually did.
Thanks, Rachel. So I'm Jen Carroll. I'm a continuous improvement clinical fellow and a physiotherapist by trade. So Rachel's led in really nicely there, talking about the modern productives and how did we seek to engage, as Rachel just said. So the opportunity to include modern productives, Stuart's already explained to you about our improvement methodology and the Rapid Improvement Week. At Lancashire Teaching Hospitals, we're one of 4 organisations supporting the initial development of the modern productive series, which is focused on how do we empower the NHS's most precious resource, which is our workforce. not only empowering them so that the NHS can survive what we're currently going through, but also how it can thrive into the modern era and beyond. So this really was a perfect opportunity to bring in some of the tools that we're developing as part of the Modern Productive series. But it is more than a toolkit, really. It is about that movement, about flipping the narrative. So there's a lot of information on this slide. A lot happened in the couple of hours where we tried to bring the Modern Productives into this rapid improvement workshop. That we were working with a number of colleagues within different roles from different settings. We explained to them about the Modern Productives, explained to them that this was improvement in action, and we were going to be testing out some tools with them. In the spirit of improvement, we wanted to really think about measurement, and as has already been described, this is about the human element. We know that in terms of productivity and data, that only tells part of the story, and Rachel shared with you the sickness absence data, but we really wanted to get into the narrative, the story behind not only what's happening in terms of sickness absence, but what are the opportunities for improvement. To bring energy into this is quite an emotive topic, a topic that has been explored previously and is being explored within multiple organisations, and we really wanted to do things different, to spark inspiration, to motivate, to completely reduce any power gradient, and to give everybody that opportunity to be part of identifying those real key opportunities that we could focus on from an improvement perspective. In terms of measurement, how would we know whether we've been successful in doing that? We asked all the colleagues to complete a Mentimeter before. We were particularly interested in thinking about how would we understand how safe they felt, to be honest and to share supportive environment to do that. And then we did some guided conversations. So on the left hand side of this slide, you can see some very tiny little squares, but some conversation cards that have been developed at Lancashire Teaching Hospitals as part of the Modern Productive series. They're very simple. They just have a keyword on the front of the card and some prompt questions on the back. In terms of the physical space, it's quite important to mention that we cleared the tables and chairs. We invited colleagues to move, to engage with other people, to go and select cards that took their interest, not be too technical about it, but what takes your interest most in terms of sickness absence. They all picked 2 cards, they paired up with a colleague, and we invited them to leave the space. They could stay in the space if they wanted to, they could go and sit in the coffee shop, they could go for a walk, and they had some time to go and have a conversation about sickness absence, utilising those prompt cards that they'd selected. We also reinforced to colleagues that they wouldn't be asked to feedback directly on the content of their discussion, but we'd use those conversations to lead into our next activity, which when they all returned, and to share with you, they all left the room. Nobody decided to stay in the room. They were all very excited. The energy had increased dramatically, and they all left the room to go and have those conversations. They came back in, we collected the cards back up, and we went straight into a liberating structure, which is at the bottom of that left-hand side of the slide, 2510, and we invited them to use that rich discussion, that deep discussion about sickness absence, and invited them all, if they could be 10 times braver and bolder, what would they recommend that we do in terms of sickness absence? They wrote those ideas down on a piece of paper, and then we went into that 2510 liberating structure. We had music, we invited movement, some colleagues were laughing and dancing. And when the music stopped, we rated those ideas out of 5. That continued, and it helped us to generate our top ideas really in terms of management of sickness absence. Next slide, please. After that liberating structure and that identification of those top ideas in terms of sickness absence, we repeated the very, very simple Mentimeter that we'd done at the start of the session. And you can see that there have been some changes. There's been some changes in how they felt that their ideas were being valued, and in how safe they felt suggesting them. There was also, you can see there in terms of about their ability to make things better, that had very slightly increased. And then just in terms of understanding the colleagues, so you can just see there's some of the things we were looking at in terms of that Mentimeter. And as it says there, we did see an increase in how they were feeling in terms of safety and feeling valued and being able to be honest in terms of their ideas and suggestions. Next slide, please. The conversation cards, we were able to identify which ones had been selected, which ones had been most selected, which ones hadn't been selected. We're able to narrow those down to the key words, but also in terms of the themes, what kinds of conversations were our colleagues having? The reason we asked them not to feedback directly is from some of our other tests of these conversation cards, that's been fed back to us, that the opportunity to have a deep discussion and not have to formally feedback on this is what we discussed and this was the key points has enabled some colleagues to have a feeling of safety and being able to really discuss what matters to them most, but then importantly using that through a liberating structure to get out what's next really. And in terms of this workshop, it was what could we do in terms of sickness absence. Next slide please. So obviously you have me here talking to you about my perspective on what we did within this workshop and how we were looking at sickness absence, trying to bring the energy in, trying to increase motivation, flatten that hierarchy. We asked them for feedback. How had they found it? This was something different. We'd cleared tables and chairs. We'd added music to our education centre. We'd told people to go off and have these conversations. We'd done things that were very different for us as an improvement team. You can see here, this is their feedback from the session. But yeah, I'll let you have a look at some of those. But there was lots of positive response. Some space challenges, which isn't unusual when you're in an NHS organisation, but on the whole, incredibly positive response and feedback in respect of how they'd found our session and where it then led us to move on to, which takes me nicely to bringing Rachel back in, because that's some of the work we did for engagement. Talked about some of the ideas we generated, but the so what, as Stuart said, what happened, what did we do next, and where has that led to?
So I think I'll just start before Rachel just drops back in there. So what we, if you remember from some of the framing that we'd said, so Jen's really nicely guided us through like the understanding, co-designing some of these solutions. What we wanted to be able to do was create a plan almost going forward. So we use the idea of a driver diagram to collect up the ideas. So the ideas are pinned down the right, almost like the secondary drivers. What were really clear for us though were them key themes that came out. So what we knew is that in order to change the status quo and reduce some of that sickness absence rate, we knew there was something really clear from the conversations, the connecting conversations around the standards as professionals and being accountable for those and making sure that we're maintaining them. The support that we provide in terms of a whole myriad of things, really. You can see again, I won't go through all the ideas, but lots of different ways that we can support colleagues to enact policy better, to understand policy and to socialise that and share that with members of staff, but also for members of staff to also understand and appreciate their role and responsibility within policy. And then finally, there was, which I don't think will surprise anybody, but there's a real role for digital and technology here. So what are the things that we can make easier for people? How can we track things better? And really plugging into thinking about how do we become more productive about this and how do we utilise our resource better as well. So at this point, I think the last bit I'll say before I bring Rachel in to tell you a little bit more about some of the ideas that we've moved forward is that method again about, well, what is it that we can do in the short term? What are the things that we're in control of right now that we can do within the resources and the envelope that we've got in a financial perspective? What are the things medium term that we find a little more difficult to do, but actually there's a place for it. We might need a bit more support. What are the long-term aspirations? So the things that I've talked about digitally, some things are a bit more transformational, will take a lot more time to change, the cultures to change, etc. And there's some things as well which are very difficult to change within the scope in terms of like work patterns that are laid down, etc. So Rachel, I'm just going to invite you back in just to finish off the final section of the presentation.
Thanks, Stuart. So just to pick up another couple of comments on that slide. I think as Stuart says, you know, a lot of the ideas that came up, some of them would be quick wins for us, whereas some of them were a little bit more difficult to implement. So some of the areas where we really tried to focus in were around standards, in terms of how do we get back to basics in terms of resetting standards and expectations, and have we got the right accountability and frameworks in place around the management of absence. And when it came to digital and technology, we've got long-term plans around some of the digital solutions that we believe that we can enact. But one of the things that we were really focused on within this is, okay, but without that solution right now, what are you doing to try and track your absence cases and making sure that they're all being managed at the appropriate stage. And where the real sort of, I think, beauty of the discussion came in was that people had some great ideas and some existing local systems around best practice, and they were able to share those with each other to try and create some peer support and some shared learning. Could we move on to the next stage? Next slide, please. Thank you. So just in terms of where we are at the moment, from an impact measurement perspective, and you'll see within the first blue column on the slide that our absence rate has come down over the course of the year. So where we peaked at around 7.64% in January, having been at over 7 for the main winter period, we did manage to get our overall absence rate down to 5.54 in August. And in particular, we've had some real success in getting that long-term absence rate down, which was our immediate focus. So that's come down from 4.84 in February down to 3.74 in September. And that plays out in terms of the reduction in the longer term cases that we've got, which have more than halved in the last few months. And then the knock-on benefit of that is that we've seen the temporary staffing usage for reasons purely related to sickness also drop. One of the challenges that we've now got is our executive team think that this is fantastic, and they are expecting a continued linear drop in our sickness absence rate. So we have had to try and get some realism around the expectation back into the discussion, because we know that as we go into winter, we're going to experience a seasonal increase in sickness absence that can be predicted. So we've already just started to see a slight increase. So there is something about how we manage that expectation, but also I'll touch on next steps in a minute, how we can get ahead of that as well in terms of our new area of focus. Could we move on to the next slide, please? So in terms of the ongoing work that's been driven by the Rapid Improvement event, we really wanted to keep the momentum going. So we have started to establish a community of practice around absence management, which also continues to evolve the peer support aspect of managing sickness and the shared learning. And we are very much focusing on behavioural change, both for managers but also staff as well. But we now really want to focus on new targeted areas of opportunity. So we know that we've got the longer term absence under control. We know that our short-term absence will go up over winter, but we want to get ahead of the curve with that, and we want to mitigate it. So the new areas that we are currently looking at are, how do we manage the first 8 weeks of absence week by week? What would we expect a manager to do week by week to stop cases getting from 1 week to 2 weeks, 2 weeks to 3 weeks, etc.? Are we doing everything that we could possibly do to try and support colleagues back to work? And we're also looking at data-driven approaches to our short-term absence as well. Looking at, do we have particular areas, for example, where short-term absence episodes typically go over 7 weeks, 7 days, trying to really understand what our data indicates to us and where it might identify that there's perhaps some slippage in some areas compared to others in terms of the way that absence is managed. So we are continuing to take the approach of, let's pick off a bite-sized chunk, let's really focus on that, and we will also be having a follow-up rapid improvement event to keep the engagement going, and that will be more multidisciplinary this time, extending beyond our nursing and midwifery colleagues. Okay, so I'll pause there, and we're happy to take any questions.
Right, before we bring people in, I mean, first of all, I just want to say a massive thank you to both our presenting teams, both our provider collaborative colleagues for giving us their really clear overview of what we're doing to progress system level improvement across our NHS organisations, and from Lancashire for sharing an absolutely vivid picture of improvement in practice with real rigour behind it. That brings forward that kind of human side of improvement around engagement, trust and psychological safety. Now, I know there'll be a million questions, and I'd already started to see hands go up, and we've got, you know, a good amount of time for this, and I can see Lynne's chomping at the bit to come in straight away. So I'll bring you in, Lynne, while we get some more questions. And if you do want to ask them in the chat, that's fine as well, and we'll pose them to the teams.
Thanks, Catherine. I probably have about 20 questions, but I'm going to ask two, if that's all right. The first one, you mentioned in an earlier slide about workforce capacity, and the workforce teams only really getting involved at the 3-month stage. So one of my questions is, as part of this, was that increased? Did you increase your workforce capacity to give more focus on this? Is one question. And then the second question, over and above the improvement methodology, did you do anything else in terms of, for example, changing your policy, changing the way that you record, I don't know, carers leave, special leave, all those types of things? And if so, do you think that's had an impact as well?
Thanks, Lynne. I'll come in on that. So in terms of additional workforce capacity, the only additional capacity that we have had in the world of vacancy freezes is permission to cover gaps. So to recruit to our vacancies and to cover maternity leave. We've not increased our workforce establishment beyond that. And some of that is because we recognise that actually a lot of this needed to come from managers, empowering managers to try and, you know, progress the cases as far as they can, seeking workforce advice where they're of longer duration and where it becomes a little bit more complex. In terms of have we done other things, we're doing lots of other things. We have tightened up our policy, mainly around the short-term absence triggers. We're yet to realise the benefit of that, I think it's fair to say, because we're not yet seeing an impact on our short-term absence rate particularly. We are doing lots of other things around. We've already got a very good wellbeing offer and a psychological wellbeing offer, but we're continuing to expand and extend that further. And like you, we're very focused on our data and getting daily data to managers. So we've done a lot of work to drop data from Health Roster into a BI portal, which means that managers have got the information that they need to hand to help them with enacting absence management.
Thank you.
Right, so we'll come to you next, Amanda, and then we'll be over to you, Sonia.
Thanks. I'm Amanda. I'm the Director of People at Gateshead. Nice to see everybody. Thanks, Rachel, Stuart and Jennifer. That was super helpful. I think we're all being put under significant amounts of pressure currently to manage absence, which is why this is probably one of your busiest booth sessions, Kath, I can imagine. But a couple of things for me. I think there's a couple of things that really resonated, and I've just messaged Lynne separately as well. The bits that you ran through in terms of some of the things that you were thinking about before you ran into the improvement workshop were really interesting. So the slippage in case management, that lack of a sense of urgency, and that reluctance to manage genuine sickness absence. I think that's just stuff that we hear day in, day out, and stuff that we repeat to our boards as when we're talking about sickness absence as well. So I think that's really key for me, and that's the nub, I think, of some of the stuff that we're dealing with, really, isn't it? So really interesting. And I guess the driver diagram that you put up on slide 21. So I don't really want to get into the weeds, but I probably do really want to get into the weeds. I'd be really interested, Rachel, what do you think was the most impactful thing that you did from that list of things that were on there in terms of the standard support and the digital piece? And I guess a kind of follow on to that would be around the standards bit. I'd be really interested in how you've engaged with your nursing and midwifery colleagues to get their buy-in. We've had some really good work in Gateshead recently, and it's because we've taken the chief matrons and worked with them really closely, and they now champion sickness absence management better than my team can. And that's really helped for us, but we're not able to replicate that across other staff groups. So I guess I'd just be interested as to whether that's been something that worked for you. And if not that, then kind of what was the most impactful piece out of that list from your driver?
Thank you. So I would say the most impactful thing has been around accountability. So within, we probably should have said earlier that within the sessions we had a cross-section of levels and managers. So we had everybody from a divisional nursing director through to ward manager. And that was helpful because we really got into some of the nubs around, like, whose role is it to do this? What support do you need from me to do that? What do we need to do to empower, the band sixes at a lower level to try and help you with this? So they were almost tackling it as a shared problem. And I think what we achieved through that is accountability, but willing accountability. So rather than a top-down level of accountability, the people that left the session actually wanted to go away and do things differently, and they wanted to work together and do things differently. And I think that has had the biggest impact for us in that they've seized the problem. It's no longer just an HR problem, as sickness absence often is. They understand their opportunity to make a difference to it.
Thank you.
Great, thank you very much. Sonia, can I bring you in, please?
Yeah, just to say thank you very much. It was really interesting. I suppose my question is, your long-term sickness went down from 106 cases to 51. Do you think there's been a change in the risk appetite within the organisation? So, I think we're, as HR colleagues, would try and keep this organisation safe and make sure we do everything we can for employees before we either let go or come back to work. Do you think the appetite within the organisation for risk has changed to move that along much quicker?
I'm not sure there's been a significant change in risk, if I'm honest. I think what we haven't now got is slippage. So what we have become very rigorous around is at 6 months there is an informed decision. It may be the appropriate thing to do for compassionate reasons to give an individual longer to get back to work, to wait until they've had the next course of treatment or until we can put adjustments in place. But that is an informed decision. It's not case drift, which is what we were seeing before.
That's really, thank you.
Great. So Claire, can I hand to you?
Hello, I'm Claire Veazey, Deputy Director at Gateshead, and just a couple of questions, I think, on the back of Sonia's there in terms of risk. Was there any learning that you had in terms of staff side and the relationship you needed to develop with staff side to work in this new way?
Yeah, certainly. So I think staff side, their predominant concern around absence management is support for disability. And there have been some challenges there, certainly, because I think sometimes what happens is when we empower people to go off and manage sickness absence, and particularly when it's at those earlier stages when they've not got HR support, they're not necessarily confident what to do when there are long-term health conditions or disability involved, and sometimes they might not necessarily make the right decisions around reasonable adjustments, etc. So we have dealt with a little bit of that, where managers have got a little bit too overexcited and probably a bit too rigorous in terms of how they've dealt with some of those situations. But we are working our way through it. We are fortunate that we've got a very good working relationship with staff side. So we are involving them in terms of identifying where there have been issues, and then obviously we're working together in terms of how we learn from that, and also how we take a shared approach to educating managers around it as well.
Sorry, could I just be cheeky and ask another question? In terms of the areas then that had lower sickness, have you done any work on those areas to understand maybe why their sickness was lower, or is that something you intend to do further along the line?
So within the rapid improvement workshop that we ran, we were really clear up front that we wanted some of our colleagues from areas with a low sickness to come along, so that they could share what do they do and what's their practice, and is it that practice that makes a difference. So that's been really quite positive. What I will say is that we have typically high absence across pretty much all of our ward areas, so it was a little bit of a challenge to find the low areas, but we did certainly focus on that where we had those good examples.
Lovely, thank you.
Great. And Emma, can I go to you next, please?
Hi, yeah, I'm Emma Rushmer and I'm Group Head of Workforce and OD at CNTW and look after part of our community care group. I suppose there's lots of questions I could ask about some of the detail and the devil in detail about the return of people to work and the impact of that. But I suppose one of my questions is, did you see an increase in employment tribunals if you therefore went on to dismiss people from the trust? And was there a sort of an agreed appetite that the potential was there for more employment tribunals if you were making tougher decisions around dismissing staff in the sickness absence process? Is my first question.
We've not seen an increase in employment tribunals related to sickness absence, no. Not saying that couldn't come in the future, but not as it stands. We have generally observed an increase, I think, since COVID in employment tribunals generally, but not for this particular reason.
Okay, that's great, thank you. And then the other thing that I just want to ask about is the monthly workforce review. You had one of the slides, so what was that? And apologies if I missed that, but I just wanted to know a little bit more about what that involved.
Yeah, so the managers who came to the rapid improvement really valued being able to have a regular meeting with a workforce advisor or business partner on a monthly basis, some quality dedicated time to go through their cases, and seek either assurance that they were handling things in the right way or advice about how to manage things. So that was something that was quite important to them. That is a bit of a challenge really in terms of our capacity. So we have prioritised the areas with the higher sickness absence rates, or where we know that we've got newer managers that perhaps need more guidance.
Yeah, thank you. We do similar, so I would just be interested because I think that's some of the conversations we are having. We offer kind of quite a lot of support out for those what we call triage meetings on a monthly basis, but we don't do it via priority area. We offer it across, but maybe that's something we need to think about from our perspective about where our resources are best placed to support the ongoing kind of high priority areas around sickness. So that's really helpful. Thank you.
Thank you.
Okay, and then I did have a question in the chat that was just building on the point that Amanda made earlier, but I think it's really valuable to explore with you while we have you with us today. And so it was Maxine that was asking a similar question to Amanda, but was really keen to hear if you've got data from a staff perspective, the people on the ground, what they felt was the most valuable change through this improvement programme.
So we've not got a strong data set around this as it stands. It's early days. I think we need to wait for our next staff survey results to come in and have a look at the health and wellbeing related questions that fall out of that. We have had some really good examples where we've been able to put adjustments in place to get people back to work more quickly than I would suggest that they might have done normally. So we are working on the development of case studies around that, so again that we can share learning with some of our other managers within the organisation.
And Rachel, you've also been going back to the Nursing, Midwifery and AHP Forum as well, which happens on a weekly basis, and you've just been presenting, haven't you, with what we've done and what's happened next. But as you said, it's early days yet, isn't it? There's not been too much that's come out of that forum as yet in terms of what they're finding most benefit from.
Right, thank you. And I think that's a really, really important point, isn't it? Because I think a lot of the research and evidence tells us that staff that are engaged are less likely to experience sickness absence, and that disengagement is a key driver. So I think, you know, building in that continuous engagement as part of your process is really, really important. I do have one more question. Is there a measure of repeat absences for those who have returned from a long-term sickness absence?
Claire, would you mind just saying a little bit more about that question, by exactly what you mean for me? Is that okay?
Yeah, of course. I think it's just really, really helpful that we've got people back to work after a long term, before it goes into an extended long-term absence. But it's just to see if, when we've got them back sooner than maybe they would have normally maybe had off for that type of absence, if they've then had another absence following that. I wonder if there's just a kind of a measure of that.
Yeah. So you mean as the return to work being sustained? So
Yeah.
we are monitoring it through our monthly sort of sickness absence data reviews that we do. There is another piece of work which we're desperately trying to finish, actually, around a rehabilitation pathway for people returning from more significant long-term absence, both in terms of the psychosocial kind of support for them, as well as you know, some of the more practical adjustments that they might need in the workplace, because we are very aware that if you get people back to work too soon, then actually, if that's not right for them, if that return isn't right for them, or they don't feel supported, then you could potentially have a further absence. But there's more for us to do around that. We're not there yet.
Great, thank you. And could I ask a question, please? And so a lot of the work, and I was involved in the Northwest with some work using the Britain's Healthiest Workplace data a couple of years ago now. But some of the learning from accessing that large scale data set was around sickness absence and recognising that, and some of the process improvement work that you've done there. But it really kind of shone a light on, from a productivity point of view, the significance of presenteeism as well as absenteeism. And I think the data sets that were referenced actually scaled this as about double the impact in terms of productivity and efficiency as sickness absence. Now, I know you've focused on improving the process around absence, but have you tracked that into or measured in any way the effect of the work that you've done on presenteeism at all?
So our next measure of, our only true measure really of the presenteeism, you know, on scale, is through the staff survey questions. So again, we're waiting for this year's to come in so we can benchmark to last year. We do run a health and wellbeing survey annually, which we call a health needs assessment survey as well, and we do get some data from that as well. But it doesn't really give us a wide enough data set to properly understand whether or not presenteeism is more of an issue as a result of the work that we're doing around sickness absence or not.
Great, thank you. Lots and lots to think about there, and thank you everybody for contributing your amazing questions. So as with all Boost, Connect and Learn sessions, we want to now move into a space where we can open up the discussion to everybody. So these Connect and Learn sessions are about reflection and connection, and thinking about what this means for you in your organisation or your context. So we're going to be going into smaller breakout groups now, and we're going to ask you to explore just one question. And the question is that, after hearing today's examples, what's one change in how we approach wellbeing, rather than what we offer, that could make the biggest difference in our organisations, or if you're working cross-organisation in the work that you're leading? The question has just been posted into the chat, so if you did want to copy that, you will have that, and then we'll give you a good 15 minutes to have a conversation in your breakout groups, and then we'll come back together to close the session. So Amy's going to send you into your groups now, and you'll be placed with people, and then we will ask you to come back and we'll close the session. So hopefully you had some really good conversations. I think we have got time. I'm not going to take like feedback from every group because that'd be unrealistic. But we have got an opportunity for anyone that wants to feedback any reflections, both on the wider session or of their conversations since. So if there are any kind of contributions that you'd like to share, it always helps us to shape future sessions as well. So anybody like to either summarise some of their conversations or offer a reflection on the session so far? Stunned into silence. Lynne, save me.
I've saved you. So we had two things. One is the form, I forgot what you call it, the informed decision at 6 months, I think would be really helpful to us. And the other thing, and some of my colleagues will know, it's an ongoing conversation about whether we have a regional policy or not. But Michelle from our group is in the process of drafting or has drafted a regional policy. So we are going to share that and see if that's something that we can discuss further.
Super interesting. I thought it was really interesting to hear you earlier as well say that when you looked at all the policies, there wasn't a huge amount of difference across them.
But I think, sorry, I just put it in there. I think that's very much linked to the presentation that we've just had. It's the application of the policy for me. It's not what the policy said. The policy could say anything. And if it doesn't matter what it says, if you didn't apply it right, then, or if you didn't apply it consistency, you're going to get those inconsistencies, aren't you? But it is something that we're going to look at.
Consistency is key, right?
Exactly.
Nicola.
Yeah, we had some great discussion in our group, and I'm going to name check Paula from TUV, who's on the call, who give us real oversight on some of the centralised teams they have in TUV to support staff. So they've got a reasonable adjustment team that go in to support managers just in terms of managing that access to work scheme, and as I say, really give that dedicated advice. One of the things that we spoke about is as team managers, there's if you're managing large teams, there's a lot of administrative burden goes into managing sickness. And is there something that we could look at in terms of supporting that burden in terms of time and process as well? And anything in terms of prompts for managers and how that can be built into systems, whether that's ESR or calendar prompts as well. So no, we had some really good discussion.
That sounds really rich, and I think that was what was interesting about the presentation from Lancashire. I think what was clear was they'd done a lot of kind of process improvement work, so they'd done that process mapping piece around some of that administrative work, and I think that does kind of really help to signpost you towards what are the quick wins, doesn't it? Maxine.
Yeah, so I suppose we didn't necessarily have the answers, but I think just food for thought. So we reflected a little bit on experiences between the private sector and the NHS, but also between NHS providers as well. So I've worked with three different NHS providers currently in commissioning, and very different approaches in terms of staff wellbeing, although we did acknowledge that there's lots more in place now these days than what there was maybe 10-15 years ago. But a really interesting point that Lucy brought up in our group was around lots of us are looking after aging parents now as well as young ones, and should we be looking at the carers policy in terms of allowing people to go and have that time with aging parents and to care for their needs, as well as juggle childcare, which can put a lot of pressure onto that person trying to navigate work in amongst all the other things that are going on in life. So not a solution, but something to think about, which I thought was quite important.
And I think it's really interesting, isn't it? Because in terms of the way that we look at population health, we really do focus in on those wider social determinants of health, and that absolutely captures some of what you're talking about there, and definitely worthy of digging into further. Emma.
Yeah, so we had Rachel, so I was just going to pick it up in terms of the I think Nicola, you've mentioned about the reasonable adjustments team at TUV. So one of the things that Rachel's talked about, which I think is a really, really good idea, is and asked if we had, as part of our occupational health, an OT who then supports people to return back or gives kind of plans around supporting somebody back to work after a long-term sickness absence. But also we talked about neurodiversity becoming more prevalent in the workplace in terms of supporting people with reasonable adjustments around that. So Rachel had mentioned that on the back of those discussions, and I thought that was really something that could be explored either by organisations or potentially regionally in terms of occupational health resources. So that was just something I thought we hadn't thought about as an organisation, but would probably be quite helpful. And we're surrounded by lots of OTs in a mental health trust, as I'm sure in other trusts you are. So yeah, that was just something to think about.
Thank you. And again, another brilliant thought and idea, and something that's becoming ever present as that we need to consider in terms of looking after our workforce. And we could probably dedicate a whole session to looking at the evidence and best practice in that area alone, couldn't we? So maybe something to think about in terms of follow on. If there's no further reflections at all, before we close, I would really love to extend an absolutely heartfelt thank you once again to our presenters. So Lynne Shaw and Nicola Morrow from the NENC Provider Collaborative, and Jen, Rachel and Stuart from Lancs Teaching Hospitals Foundation Trust. There will be an evaluation for this session that you're going to receive automatically by email. Please do complete this, as it helps us to continuously improve our approach and ensure that these learning sessions are impactful for all of you. And then I guess my final call to action is that if you'd like other people to view the recording of today's session, the film will be available through the Boost platform. So please encourage others in your organisation and teams to sign up for Boost. It's free for all those working in health and care, but also citizens and members of the public across North East and North Cumbria. We do have circa 100 improvement case study videos through our YouTube channel for you to explore. And I think one of the things that we say quite regularly is, you know, many of the solutions to many of our problems already exist within our system. And so many of you have contributed to those improvement case studies. So do encourage people to use them. And if they become members of Boost, I know you've already signed up because you're in this session, but they'll all have access to our future events, tools and opportunities to connect and learn with colleagues. So thank you all for your time today. Let's keep sharing what works and stay curious, and have a great rest of your afternoon. Thanks, everybody.
Thank you, Catherine.
Bye-bye.
Thank you.
Bye.
Thanks.
Bye.
Bye.